welcome Dr. Lindsay from Fred Hutchinson. It's nice to see you there, Julian. Julian is a clinical researcher at the Fred Hutchinson Cancer Center in Seattle, and he's also affiliated with the National Centre for Infection and Cancer and Transplantation, the NCICT, which is in Melbourne, Australia. He has a most recent clinical background as working at the Royal North Shore Hospital, although I first got to know Julian when we were working together at the Royal Brisbane Women's Hospital. He's got a fantastic track record from an academic perspective already at such an early stage of his academic career. And it's all built upon his excellent clinical expertise and the opportunities that he's been able to develop across each of these institutions. And he has a particular interest in the prevention of opportunistic infections in patients with blood cancers.
Okay, thank you very much for that very kind introduction. All right, hello everyone. Good morning and good evening to all of you dialing in. I appreciate the opportunity to talk today. So today I want to be chatting about pharmacogenomics to optimize antifungals. And as Jason pointed out, I'm a clinical research associate at the Fred Hutchinson Cancer Center, and I was a former BMT pharmacist. So I come with a clinical background, but purely doing research into how we can optimize antifungals and other drugs in opportunistic infections now. So I'd like to first acknowledge land. The Fred Hutchinson Cancer Center acknowledges the Coast Salish peoples of this land that I'm currently on, the land which touches the shared waters of the tribes and bands within the Duwamish, Paliup, Suquamish, Taliyip, and Muckleshoot nations here in Washington State. So in this rather brief talk today about pharmacogenomics, first I'm going to give a little overview of the background of using pharmacogenomics for those of you in the audience that aren't too familiar with it, because it is an emerging therapy or an emerging tool that we have for therapy. Then I want to talk about how we can incorporate pharmacogenomics into antifungal therapies. And finally, a really brief topic, I don't want to take away from the other speakers, about how we have implemented the service here at the Hutch and we're aiming towards. So firstly, the background of pharmacogenomics. So pharmacogenomics or pharmacogenetics, you'll often see written as well, same thing, is a field of research that studies how a person's genes affect how they respond to medicines. Now, largely, this is talking about liver enzymes, which metabolize drugs. So the first real enzyme that was used in pharmacogenomics was CYP2D6 variants, as this is important for converting codeine into morphine. Or what we're going to go into detail today, another emerging enzyme that's been well studied is CYP2C19, which converts voriconazole into the inactive form of voriconazole N-oxide. So just a little brief terminology. So variants or polymorphisms of a single gene is what the genotype is that we're going to be looking at. And I'm sure we'll get into more detail with the later speakers, but in simple terms, there are two alleles, and there can be either homozygous or heterozygous. So say G is wild type or a normal enzyme, say. If it was GG, that would be homozygous wild type. TG or one SNP, oh, shouldn't have happened. One SNP or single nucleotide polymorphism would be heterozygous for that. And if there was a single nucleotide polymorphism or SNP on both of those alleles, it would be homozygous. So all three of these options will give you different phenotypes. So the genotype is often written as star number, star number. So *1/*1 would generally mean the normal allele for both alleles, or *1, *2 would be heterozygous *2. And a great example of this in nature is the Gouldian finch, which can have a single nucleotide polymorphism in genes that code the color of their faces. And a wild type will be plain black, a polymorphism that is homozygous, so both will be orange. But if they're heterozygous for that polymorphism of that single nucleotide, they come as a different type again. And so that's just a little background so that you can visualize that. Now, the phenotypes, when we're looking at enzymes that metabolize drugs, are often just categorized as poor metabolizer, ultra metabolizer, normal, and so on. And we'll get into that. So here in the US, the FDA monitors drug safety, and it now includes pharmacogenomic information on the label of over 200 medicines. So it's definitely something that's been recognized as an important part of patients' therapy. Now, a little bit more in detail of how these pharmacogenomics affect enzymes. 2D6 is that great example of a drug like codeine that's absorbed, but then is converted to its active form of morphine by that enzyme CYP2D6. And so if we have a look at different patients' phenotypes, PM's poor metabolizer, EM's extensive metabolizer, or ultra metabolizer, you can see that people that are poor metabolizers have almost no circulating morphine. Extensive is a normal, a moderate amount, and ultra metabolizers have a very high amount, and that's because that enzyme is responsible for converting the inactive to active drug. Now, on the other hand, CYP2C19, which is more relevant to us, is the enzyme that metabolizes voriconazole, the active drug in the body, into the inactive voriconazole N oxide. So adversely, the ultra metabolizers have an extremely low level because they're metabolizing at a higher rate than a regular, so extensive intermediate metabolizer. And those poor metabolizers that can't metabolize the active to inactive drug have extremely high levels and super therapeutic. So you have to consider what the enzyme does when you're thinking about the genotype. So very quickly, how does one test the genotype of a patient? So it is a real-time PCR test. So for example, the Thermo Fisher TaqMan assesses SNP or single nucleotide polymorphisms of assays, and you can see the array of all the different enzymes that it can test and their unknown polymorphisms of that it will test for in a total panel, but you don't necessarily need to test for the entire panel. So if you have your own PCR machine, this is the one at the Hutch. It's a Quant Studio 6 Flex. First, a sample, blood, saliva, or a swab is extracted for DNA. That's run in the PCR. It's a fast turnaround time. You can generally get that done in 24 to 48 hours, but it's very expensive because you're not batching. Now, you could also send it away to a lab that has this facility there. It's a much slower turnaround time, around a week, but because of transport, and they batch it, but it's much cheaper so that they can batch multiple patients at once. You can get a whole panel for a couple of $100s. Now, like I mentioned, samples can be blood, saliva, and swabs, but you have to be very careful about the patients that you're working with. So if you test the blood of an allogeneic transplant, you're testing the liver function of their donor, which is absolutely irrelevant to what the patient is doing. Likewise, if you test the blood, the saliva, or the swab of a liver transplant patient, you're testing what their old liver did, which is not going to give an indication of what their new current transplanted liver is. So you have to be very careful with the swabs in transplant patients. Very quickly, saliva and swabs for allogeneic transplants theoretically could be used, but that isn't validated yet at any center, but we're working on it. So this is what a general full panel, if you were sent away, was to look like. The CYP panel specimen's blood. The genotype would be that star number, neg or wild type or star 1. And then they'll give you the phenotype, so what that actually means, the genotype means. And that's a full panel, 2C19, 2C8, 2D6. Now, what to do with that panel? A really great resource is the Clinical Pharmacogenomics Implementation Consortium, or CPIC, that have an array of guidelines that you can use. So if you look at the gene drug guideline in CPIC, they have 118 different genes, 261 drugs, and they'll often have a guideline that you can click to read through the level of evidence for using pharmacogenomics for that drug. And so forth. And so looking at 2C19, as this is the most relevant for antifungals, this is what the 2C19 guideline for CPIC looks like. They classify ultra rapid metabolizer, rapid, normal, intermediate, and poor. And that is the diplotypes or the genotypes for those phenotypes. So star 17, star 17 homozygous is the ultra rapid metabolizer, about 5% of patients. About 30% of patients are rapid, so that would be the heterozygous for star 17. Normal metabolizers, just that 1-1. and then intermediate, there's array, and poor, there is array. Depending on the ethnicity, it's about a third of patients that are in that rapid, about a third normal, and about 15% poor metabolizers. Ultra rapid is a little bit more rare at 5%, although we have seen actually a lot of those patients, especially when we've had patients prior to using pharmacogenomics, they've been subtherapeutic for weeks of trying to get that level up, and we thought something's going wrong. We have this test now, and lo and behold, they came back as those ultra rapid metabolizers. So then what do we actually do when we find out what their phenotype is? And these are also in the guidelines. However, I think the CPIC guidelines for dosing is probably a little bit more vague than you would need for interpreting and giving recommendations. They're sort of a little bit aged now. 2017, there's been a lot more studies that we'll really briefly go over, but essentially it sort of says avoid in those ultra rapid or those poor metabolizers and normal doses for normal. But we have a little bit more information now to go with. So what about, let's look at different antifungal agents and their metabolism. And I'm going to be very brief here, so it's not the most thorough job, but just to go over quickly. So fluconazole is renally excreted as unchanged drug, a very small amount of hepatic metabolism. Isavufluconazole, CYP3A4, and probably the most CYP3A5 out of any of the antifungal drugs, as well as UGT glucuronidation. Itraconazole is hepatically cleared by 3A4. POSA is actually minimally metabolized. Most of the drugs cleared about 60% unchanged in the feces. There is a little bit of hepatic UGT1A4 glucuronidation and it's a substrate of P-glycoprotein as well. Now, voriconazole, as we've discussed, major CYP2C19 substrate, as well as a little bit of 2C9 and 3A4. Amphotericin, all the echinocandins, flucytosine are not hepatically metabolized or minimally hepatically metabolized, mostly by degradation. The newer agents, olorofilm and ibrexafungerp, are totally hepatically cleared, predominantly with 3A4. And so just to give you an idea, that's the commonly used antifungal drugs, how they're metabolized for the clearance. And we need to be thinking about that then when we're talking about setting up a service and how we can use pharmacogenomics with these agents. So there's not much of a utility for pharmacogenomics if you don't have a lot of the properties of a drug. There's some criteria to use that you want to be using. So first of all, the pharmacokinetic properties of the drug. Is it cleared? Is it cleared by an enzyme or something that could have genetic variability? The individual variability or PK/PD of that drug. If you have a new drug brought to market, 1,000 people were tested, and no matter what their level was, it didn't have any issues with safety at higher levels. It didn't really have a minimal level that it had an effect, then there's really not much point in adjusting, although that would be a very uncommon drug, so we know how uncommon that is, but you have to consider the interpatient variability, or 99% of patients had the perfect level, and we can't really find any sweet spots, so there's not much to change there. So are there clinically relevant pharmacogenes that we can use to actually that affect the drug's metabolism that we can work with? And those three are all practical. Can we think about those things when we're talking about implementing pharmacogenomics? But then you also have to consider, is there evidence for pharmacogenomic associations enough to actually implement that for the safety and efficacy of azole drugs? Now, you might have guessed it, voriconazole is the perfect candidate for pharmacogenomic implementation. It's predominantly 2C19 metabolized, and 2C19 itself has very saturable kinetics. So the minute it's saturated, then your drug will skyrocket because it can't metabolize any more. There's wide interpatient variability of the different CYP2C19 phenotypes, as well as the actual metabolism of it, it also has a narrow therapeutic index where we know levels that are too low are not going to achieve the desired antifungal effect. Levels that are too high have a lot of toxicity. So we want to have that drug in the perfect spot. We have a target of 2C19 that can be measured. And then finally, there's good evidence for pharmacogenomic intervention in this drug. And it's very accessible. 2C19 testing is widely available. It's more just that time frame of whether you have to send it away or you could do it in-house. Looking at some other antifungal drugs, unfortunately, I don't have amazing news in that area. There's been one single study on posaconazole back in 2018, about 130 hematological malignancy patients in South Korea. They actually interestingly found that UGT1A4*3 polymorphisms were an independent risk factor for absorption of the oral suspension. However, this isn't as relevant today because most people are on IV or tablet form, and obtaining therapeutic levels aren't too much of an issue. But it's interesting to note that if you need to use that agent and you're having issues with absorption, that there is some evidence there that it could be, it's a pretty rare polymorphism. So could be a out of the box recommendation to get that tested. Now, other drugs where we could potentially have some pharmacogenomic interventions, but there's a lack of data, is itraconazole, olorofilm, and abrexafunga, because they're all metabolized by 3A4. However, CYP3A4 has less variability than CYP2C19. And there's actually currently no drugs with a strong enough evidence base to test for 3A4, despite the fact that we do have known polymorphisms of 3A4, one of which is a reduced activity, but it's extremely rare in less than 1% of patients. But in saying that, there could be something. I know there's a lot of work going on in this field, so keep an eye out for those three drugs in 3A4. The other thing that may have more potential is 3A5. Now, 3A5 is known to have different polymorphisms that affect other drugs. Isavuconazole is predominantly metabolized by 3A5, but the problem is we haven't really found that isavuconazole has a narrow therapeutic index, especially looking at different breakthrough infections of isavuconazole. So the utility of all of these antifungals is probably still, there's not as much evidence as voriconazole to use. So something to keep an eye on the research, but not to go to clinically and start intervening. And as we discussed, other agents like amazone and echinocandins are excreted in their active form and don't go through metabolism, so there's no real targets to look for. Now, as a little summary, the CPIC guidelines, there's 26 guidelines published, 22 genes and over 65 drugs. And you can see that this is that they recommend testing for this drug. You can see CYP2C19 have voriconazole there, strong recommendation. The 3A5 is there. That's the one I was mentioning that isavuconazole is metabolized by. However, there's only guidance for tacro dosing with CYP3A5. And you can see there probably a lot of you already do some pharmacogenomics, but don't realize, like when we have to test for 6-GDP, if they have before starting respirocase to see if they're wild type or if they're deficient in G6PD for respirocase dosing to prevent hemolysis. If you work in heme, if you don't, then you probably haven't done that. All right, so very briefly, there is a lot of evidence for CYP2C19 guided voriconazole dosing. However, a lot of it is based on prophylaxis. They have time to get the test, preemptively do it. Probably the study that showed the most benefit was this evaluation of CYP2C19 genotype for voriconazole prophylaxis in allo patients. So in the pre-allo workup, they were able to do a CYP2C19 test for everyone. They had weeks because they knew the patient was going to get a transplant. They knew they were going to start voriconazole on day +1, And you can see that in the historical cohort that was a rapid or ultra-rapid metabolizer, 70% of patients were subtherapeutic at that first level. And when they intervened and gave a higher dose to those rapid metabolizers, ultra rapid metabolizers, only 15% were subtherapeutic. So they clearly showed a benefit to using it. So considerations for starting a pharmacogenomics service. First of all, you really have to think about what the aims and benefits are of the service. Do you want to achieve therapeutic levels more rapidly? Is that actually important, or is the drug sort of a long-term drug? And that's a good example of that is clopidogrel. Clopidogrel is a 2C19 substrate. However, the benefit of clopidogrel is not immediate. So, it will have an effect over 3 months or so. So you sort of have a week or two to get that level back, check and adjust accordingly, or choose to use another agent. However, what we're sort of aiming towards with voriconazole is if you have a patient that's dying of a fusarium infection, voriconazole is the only agent that the fusarium is sensitive to, you want to get to therapeutic levels really rapidly. And do you want to avoid toxicity? So the 6-GDP is a good example of respiricase. We just want to test, see if they're deficient or not, and give the drug straight away to avoid that hemolysis. We're not interested in sort of getting levels or aiming for levels more rapidly or anything like that. We have to get a test quickly, and it's a yes/no answer. Do you just want to reduce the cost of medication, maximize therapeutic effect, or all of the above? That's also reasonable. And I've sort of alluded to it, but what's the time frame of the therapy and the testing? So you might want to know it straight away, like that 6-GDP, or a patient that is currently has the fungal infection. Or you could argue that prophylaxis is less important, especially if they're not a high risk already, but an allotransplant, say day one, you could probably have time to sort of give it to them, do a level, give it to them, do a level. So maybe in that scenario for prophylaxis, you might wait for a subtherapeutic level to come back before doing a CYP2C19 test. And what context is the agent being used is obviously important. Excuse me, it's a long day of talking. So just very briefly, at the Hutch, what we're sort of piloting right now is when voriconazole is initiated, a normal loading dose and maintenance dose is charted, normal levels are being done, and we're also sending away a CYP2C19 genotype for all non-allogeneic transplants. Like I said, we're trying to get that buccal swab validated for these patients, but that's currently not done. And then we usually get this level or this phenotype back within 48 hours, in which we can dose adjust. And then very lastly, this is a very messy table, but essentially, as I alluded to, this is the CPIC therapeutic recommendations for the ultra rapid, normal, intermediate, and poor metabolizers. But there's also a summary here of the different publications using CYP2C19 and the dosing strategies. And we've sort of come up with a pilot template nomogram of the standard 4 milligram per kilogram for those normal and intermediate doses. But for the rapid, increase that to 5 to 6 milligram per kilogram. So essentially what that means is it usually would come back within 24 to 48 hours. They're already getting that load of 6 milligram per kilogram, and we just continue on those. And same with the ultra rapid, but if there is another agent, it's probably safer for those ultra rapid metabolizers to use another agent if it's possible. The same with poor metabolizers, a half dose would be a potential option. But if there's another agent to use, then you don't have to risk that toxicity. So this is very early phase. We're trying to set up a study, currently looking at this prospectively. And there's probably a little bit of resistance from some of the clinicians, especially those, like I alluded to, where it's prophylaxis. We don't necessarily need to intervene straight away if they're not in a high risk yet. So depending on how different studies go, we might change to only be using it for patients with subtherapeutic levels, but it's early days, so I can keep you up to date with that. And at that is my talk. Thank you very much for listening, and I'm sure we'll have lots to discuss at the end of the whole session.
Thanks, Julian. That's fantastic. We'll move on to the next presentation. As you say, we'll come back for the Q&A a little bit later on.